Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Welcome to those of you who are able to join us today during our Lung Cancer Living Room. I'm Danielle Hicks, Chief Patient Officer here at GoTo Foundation for Lung Cancer. And for those of you who might not be familiar with our Living Room program, it's a support and education series created specifically with people diagnosed with lung cancer and their caregivers in mind. The goal really is to bring to you live and in real time educational talks from key opinion leaders in the lung cancer community, and really in a format and lay language that's easy for you to understand. We know that people watching tonight come from around the globe and consist of people living with varying types of lung cancer who are undergoing various types of care. We want you to know that we are here for you and that we believe wholeheartedly that educated and empowered patients do better. So thank you for joining us. Our speaker tonight is Dr. David Carbone. He is Professor of Internal Medicine and Director of the James Thoracic Oncology Cancer Center at Ohio State University Comprehensive Cancer Center. And tonight we're going to be discussing updates from the American Society of Clinical Oncology, or ASCO. I know this is always year after year a very anticipated event for us to be able to share with all of you all the exciting things that are coming down the pike in lung cancer. Their annual conference occurs every year in late May, early June, where data is presented on the emerging science. Tonight, we're going to go over information specific to lung cancer in multiple categories, including targeted therapies, biomarker testing, immunotherapies, early stage diagnosis, and small cell lung cancer. But before we get started, I'd like to ask Dr. Carbone. I tell you guys all the time, I could read a very long bio, but it comes across as very impersonal. So I would like to ask him to tell us a little bit about himself and why he chose lung cancer as a primary area of focus.
Well, I've been primarily focused on lung cancer since I was a resident, basically, and I was MD and a PhD student at Johns Hopkins, and I got a PhD in genetics. And 30 years ago, genetics was completely useless in cancer, or in medicine almost, except for inherited disorders. But I started seeing some papers coming out on how bad a disease lung cancer was, how common it was, and that they were starting to discover recurring gene mutations in that disease. And I figured there was a high likelihood that some of these gene mutations may represent approaches for effective therapy development. And I've worked in lung cancer and done lung cancer research since 1990, basically. So
Ever since. That's great. And I know as many of you watching tonight are very, very familiar with Bonnie Adario, who most of you know is my mom, and where my lung cancer journey began back in 2003. And when she had started the foundation in 2006, and then the sort of sister foundation, if you will, the Adario Lung Cancer Medical Institute, Dr. Carbone was incredibly involved, was and is incredibly involved in all of the work that both organizations do. So thank you so much for being here with us tonight and being mindful of time. We've got a lot to cover over the next hour. Let's get to it. So we're going to start with targeted therapies. And a lot of work has been done in the past decade and a half in researching and discovering biomarkers and appropriate therapies that will directly target them. And tonight we want to talk a little bit about some of the new findings in this area of targeted therapies. So I think I want to start with KRAS. You know, KRAS is, most people know, and Dr. Carbone can dig a little deeper into, is one of the most common mutations in non-small cell lung cancer. And for a very, very long time, we didn't really have a good way to treat it, at least not targetedly. the first targeted therapy for people diagnosed with KRAS, specifically the KRAS G12C mutation, Lumakras, was approved last year as an option for this subtype where people with cancer had already been treated with another therapy, such as chemotherapy. But, interestingly, and as we quite often see, only some of those folks diagnosed with KRAS G12C positive lung cancer responded well to this therapy. So there's a lot of work being done in this area, and I want to jump into that. And before we jump in, and I'm going to ask Dr. Carbone to talk a little bit deeper about this as we move forward. You're going to hear me at least, because in lay terms, I feel like it's easy for folks to understand, say subtype. Off and on this evening. Many of these top level mutations, such as KRAS, have subtypes of that mutation. And so sometimes it gets a little bit confusing. But tonight we're specifically talking about KRAS G12C. And I want to jump in, Dr. Carbone, and talk a little bit about the Crystal One trial and adagrasib.
Oh, great. Thank you. So KRAS actually was, I think, the first recurring genetic abnormality discovered in lung cancer. And KRAS is a gene that is from a family of oncogenes, KRAS, NRAS, HRAS, and was always something that we tried to find effective therapeutics for and failed multiple times. But very recently, these inhibitors that Danielle was talking about were developed that target a very specific abnormality in the KRAS gene. KRAS mutations are the most common type of RAS mutations in lung cancer, and G12C, which is a specific amino acid substitution at amino acid number 12, which is where it got its name, is one of the more common types of mutations. And these drugs specifically target that abnormality. So this Crystal One trial, which we talked about, is a trial that describes the results from a second KRAS inhibitor called adagrasib that is also specific for the G12C type of KRAS mutation. And what they presented was that virtually every patient with lung cancer bearing that mutation had some clinical benefit, and over 40% of them had what we call objective responses to the drug, which is quite high and indicates a very active drug. And excitingly, they also demonstrated that there was activity against brain metastases, which are a very important problem in patients with lung cancer, spread of the cancer to the brain. And drugs that aren't effective against brain metastases are not as good for patients. And this study showed that of the patients with brain metastases, most of them the brain metastases responded to this adagrasib drug. And we really don't know how well sotorasib works in the brain, but this drug did demonstrate brain activity, which is very clinically important.
Yeah, it is. I know we talk a lot here in the living room about the propensity for lung cancer to travel to the brain and how hard it is to treat that type of metastases. So I think it's very encouraging. Can you tell me off the top of your head, when we think about and we talk about here in the living room a lot, sort of the pie and the pieces of the pie and all of these mutations that sort of fill this pie up, what percentage of non-small cell lung cancers are KRAS, and then what percentage of those are G12C? Do you know off the top of your head?
Well, so
Roughly.
KRAS mutations are almost always found in adenocarcinomas and not squamous carcinomas. So about 70% of lung cancers are adenocarcinomas. And of the adenocarcinomas, it's probably about 25% have KRAS mutations, and something like 40% or 30% of them are G12C. So it's a pie, a piece of the pie, but it's a start. And companies are developing drugs against all of the other specific mutations in KRAS. And I look forward in the next few years to seeing active drugs against many different KRAS mutations.
Yeah, I couldn't agree with you more. I know I've said during Best of ASCO in years past that I'll never forget my first ASCO. And I was an absolute virgin to the conference. And I was really discouraged. This was maybe 15 years ago, to not see a lot of things in the pipelines with a lot of drug companies for lung cancer, let alone all of these sort of subtypes of lung cancer. And now you attend this conference and you're hard pressed to find somebody who's not working in lung cancer. So it really is not that being diagnosed with lung cancer is ever exciting, but it's an exciting time insofar as progress goes for the treatment of it. So we talked about the Crystal 1, and then there was the Crystal 12 or 1-2 trial, and that was pretty much the same trial, just what? Can you explain how that worked?
Unfortunately, right now, with the first line chemoimmunotherapy for most non-small cell lung cancers, we have pretty limited options in second line until the last year or so. And it was typically a drug called docetaxel. The majority of patients after their tumors became resistant to chemoimmunotherapy were treated with a drug called docetaxel, which is a decades-old drug. And it's a good drug, but it's not a game changer, let's put it that way. The response rates tend to be in the 20% range. The response duration is usually just a few months. Some patients have more benefit than others. And the Crystal 12 trial directly compares the adagrasib with docetaxel in these patients in order to demonstrate that in patients with KRAS G12C mutant tumors, that this, if the trial is positive, that adagrasib would be the preferred option for use in those patients over docetaxel. So I think it's important to do these kinds of studies, to do a head-to-head comparison.
That's great. And this is not something that we talked about prior to this meeting, but it's kind of popping into my head. And I want to remind everyone who's watching live that if you have questions, please put them into the chat on whichever platform you are watching on, and we will make sure to get them over to us and answered for you. But my question is, and I know we've fielded calls through our support line from patients who are KRAS positive but not G12C. Is there work being done outside of G12C?
Yeah, I mentioned just a minute ago, there are multiple companies working on inhibitors for KRAS that target the other amino acid substitutions, G12D, G12C, G13. And there are candidate compounds for those different mutations, and there are even pan-KRAS inhibitors that target all the mutations that are being developed. And we'll have to see how active and how safe they are. But like you said, it's very exciting that companies are putting huge resources into developing drugs relevant for lung cancer, which was not the case in the past, for sure.
Yeah, no, absolutely. Okay, let's jump into EGFR. We know, and most folks who are veterans to the lung cancer living room know that this is one of the first sort of guy out of the chute, at least since I've been around in this space, to have a targeted therapy for it. And in the more recent years, Tagrisso or osimertinib has been the standard of care first-line treatment for EGFR positive non-small cell lung cancer. But many patients do develop resistance, and these are calls that we also field. What happens next? Resistance meaning that the cancer starts to grow or spread again, and more treatment options are needed. Let's talk a little bit about what's happening in this area, more specifically the Chrysalis II trial.
Yeah, just as a preface, all these names drive me crazy. the acronyms. And if I can't keep them straight, I'm sure patients can't keep them straight. And then the drug names are complicated. But the fact is that there's a new drug that's called Amivantamab that it's a kind of a totally new design from most of the antibodies that are in clinical use. It actually has an antibody usually has two arms, and the two arms usually bind to the same thing, like Keytruda, pembrolizumab, will have the two arms, each of them binds to the PD-1. But with amivantamab, one binds to EGFR and one binds to MET, the gene called MET. And in this study, the Chrysalis II study, amivantamab was combined with a novel TKI, like osimertinib, but it was called lazertinib. And they tested this combination of this antibody with lazertinib, the drug, in patients who progressed on after treatment with osimertinib. Now, it should also be mentioned that this is after progression on osimertinib and chemotherapy. So in this trial, they found that there was a very high response rate in these patients. The objective response rate was 33%. But again, most patients benefited, had a clinical benefit from this combination. And I think that's very exciting. And it makes some mechanistic sense because a common mechanism of osimertinib resistance is overexpression of the gene called MET, which bypasses the EGFR gene and keeps the cancer going if you block the EGFR gene. So this antibody blocks both.
And I think that's important. So I want to pause right here because you used the acronym TKI, and I would like to ask you to explain to those who might be newer to this space what that means.
Well, it's a generic label for a whole class of these drugs, and osimertinib is a TKI, and erlotinib is a TKI. That stands for tyrosine kinase inhibitor. Most of these, the targetable oncogenes to date, except KRAS, are kinases, and these drugs act by blocking these kinases. And kinase is another word for a protein that puts a phosphate group on other proteins, and that is typically used by cells to turn them on and make them grow. And so these kinases get activated, they phosphorylate their targets, cause the cancer cells to grow, and these TKIs, tyrosine kinase inhibitors, inhibit specific members of those families that are driving specific cancers. So that's what TKIs mean. It's a class of drugs.
Perfect. Thank you so much. And then I want to touch a little bit on MET because I think it's important for folks to really understand sort of this process of resistance, right? Like most people think, no, my doctor told me X, Y, or Z was driving my cancer, and there's a drug that will target it. And we don't really talk about resistance until it happens. And so I think people are quite often taken aback, like, why did this drug start working? And I hate to say that cancer gets smart, but it like most things in our body, even in the positive way, they find ways to keep things positive. And in the mind of the cancer, the positivity is continued growth, right? So can you talk a little bit about resistance before we jump too much further into this?
Well, it's a very important topic with these targeted therapies and driver mutant tumors, because even though we're having great success in shrinking these tumors and improving patients' quality of life, they are not a curative treatment. These treatments cause the tumor to shrink, but it doesn't kill off the entire tumor. And so what we've been intensively studying is why tumors develop, how they develop the resistance. And we could spend a whole hour talking about those mechanisms, but generally it's either reactivation of the target gene by a second mutation, and T790M was one that was common with first generation inhibitors, for example, or a bypass mechanism, and that's, like I was telling before, could be overexpression of MET or other kinases that bypass the need for the primary kinase. So people have been studying how to look after the tumor becomes resistant, look at it again with biomarkers to see how it's changed, how it's adapted to be resistant to the drug, and see if we have drugs, which we often now do, which specifically target that bypass mechanism. And Amivantamab is an example of exactly that. But I think I've mentioned in other fora, I would like to see how we kill tumors dead in the beginning and not be chasing resistance mechanisms in the end. Like I said, these drugs shrink tumors dramatically, but they don't kill that last kernel of the tumor. And it sits there and works on developing resistance until a clone grows out. And if we could find smart upfront combinations that killed off that stem cell-like clone that was resistant to the original therapy, we might be able to get cures in this disease. And we have a clinical trial right now with a stem cell targeting drug combined with osimertinib, where we're trying to see if we can accomplish that.
Yeah, that would really be something. And I think these are the things that we're shooting for, and and that we're hoping for. And I think, to put sort of a positive spin on that, because I don't think you're not going to find anybody to disagree with how do we get rid of the whole tumor to effectively cure people of their cancers. But in the meantime, where we have come with targeted therapies and now, immunotherapies alike, is we're buying people sort of this time, right? That 15 years ago, which isn't really that long ago, most of this population didn't have.
Yeah, the average survival for metastatic lung cancer patients was in the range of 4 to 6 months when I started. That's from diagnosis until death. And we weren't even confident that anything we did would change that. And some of the recent trials, like the ALEX trial and the CROWN trial, for example, in ALK fusion positive patients, have shown that almost 70% of people are living 5 years now, which is a dramatic improvement, and years of life of good quality, low toxicity life given back to these patients, which is a major advance. But I keep reminding myself that if you're 50 years old and you have an ALK fusion positive tumor, even 5 years doesn't sound so great. And we have to keep striving to make that better and longer, applied to more people. And like I said, work towards a cure rather than just kicking this can down the road.
Yeah, absolutely. Amen to that. It stayed going back to your comment about the 4 to 6 year diagnosis to death.
4 to 6 months.
4 to 6 months. Sorry. It stayed like that for a very long time.
Yeah.
Right. Because I remember when I first entered the game, which was way after you did. And I was at first attending these conferences and listening to these presentations, and it was like trying to navigate a Japanese subway map. We have come a long way, and that's insanely promising that what you're talking about today in the trial you just described is not necessarily out of reach. Like you said, when you first started, like we never thought we'd get past that 4 to 6 month sort of place. And now here we are. Yeah.
But even with all these new drugs, we still have to keep in mind that not everyone has a targetable mutation, and then not everyone responds to immunotherapy. And there's still a large segment of patients for which we don't have an effective therapy, and that's a real tragedy. So we have to keep reminding ourselves to work harder to improve on that.
I could not agree with you more, and not just those folks who don't currently qualify for any of the newer, sort of latest and greatest, but those who aren't even offered biomarker testing to see whether or not
The worst
they.
thing is a missed opportunity that they
Yes,
have a driver and the doctor doesn't test for it or doesn't recognize it even when they get the result back, and they get put on some random chemo and have trouble and never have the opportunity to use the appropriate therapy. And so we
yeah,
really have to work on application of best principles everywhere. In addition to just discovering new things, we have to make sure they get implemented in practice.
yeah. Yes, 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 yes to all of that. I could not agree with you more. I do have a question about HER2, but I want to kind of close out this EGFR portion and talk about an early phase trial. And I'm just going to stick with the Taliso V and not try to say the say the actual name. But can you talk to us a little bit about that? Still in that CMET sort of space.
Yeah, so Taliso V is what we call an antibody drug conjugate. So it uses this antibody moiety, which is a protein that's a natural type of protein that your body makes to fight infections, that has been engineered to bind to the protein MET. And in addition to binding MET to MET, they've bound chemotherapy molecules to the antibody. So the purpose of the antibody here is to deliver the chemotherapy to the tumor. And one of these antibodies is called Taliso V, and that is being tested in multiple clinical situations and showing a high response rate in for example, MET exon 14 mutated patients, as well as patients with EGFR mutant tumors who've become resistant to Tagrisso osimertinib by overexpressing this protein MET. So it's another option for patients both in the resistant setting and as a primary therapy.
Fantastic. One quick question that I think you can answer that came in regarding the trial that you referred to about osimertinib and the stem cell drug. Folks are wanting to know if that is open, if that is an
It's
open
open
trial.
and accruing, and we have I don't know exactly how many patients, a handful of patients on it already. It's actually, I looked recently on clinicaltrials.gov, and it was listed, but it was listed as not recruiting. There's an error in clinicaltrials.gov, and I told our trials people to make sure that gets fixed, but it is indeed open. And we're seeing that this combination, which we're testing, is osimertinib plus a beta-catenin inhibitor called tegavivint. And we find that it's super well tolerated. We haven't seen any side effects to date that were attributable to the new drug. And patients have had, knock on wood, not a single patient on that trial has progressed yet. So, I'm hopeful that this will be a new approach in treating these patients, but we'll see.
Fantastic. Thank you. Okay, let's talk a little bit about, still in the EGFR realm, for those who are still following, about exon 20. We know historically that folks with this particular mutation did not respond well to some of the standard targeted therapies that were previously approved. And I know a lot of work's been being done there. Can we talk a little bit about what's happening there? We can start with the CLN 081.
All right, let's back up a little bit. I think even a lot of doctors don't understand that EGFR mutations are not all the same, right? So, the very first ones discovered were two. There's one called exon 19 deletion and then L858R. Those are exon 19 and 21 mutations, and they're by far the most common EGFR mutations. And they're the ones that respond very well to first, second, third generation drugs. And but the more and more we sequence EGFR, the more we find hundreds, I would say, of different mutations in EGFR that seem to be true drivers of cancers, but are not these two common mutations. One of the more common ones is exon 20. And actually, there was a beautiful paper by John Haymock in the MD Anderson group recently that looked at dozens and dozens of these mutations and grouped them into functional categories, some of which are better treated by osimertinib, but interestingly, some of them are better treated with an older drug called afatinib. And I think that kind of thing is super important in developing new drugs for EGFR, specifically for these uncommon mutations. But if you as a patient have an uncommon mutation, it's common. It's it's your 100%, and you really need the right therapy for that mutation. And one of the more common uncommon mutations was exon 20 insertion, which the standard inhibitors didn't work very well at all in. But it actually turns out there's two kinds of exon 20 mutations. Certain mutations respond very well to osimertinib, but others don't. And so companies have been developing drugs specifically for exon 20, and now there's a couple of them approved, but the one you mentioned was presented at ASCO, CLN-081, and in that study they had a response rate, I've got it right in front of me here, confirmed response rate in the 40% range, with, again, virtually every patient having some kind of benefit from the drug. And including complete responses. They had, in that study I'm looking at, 5 patients who had complete disappearance of their tumor. So this is very exciting and promising that as our state of knowledge and testing for these mutations develops and we learn more and more, we may even tailor drugs depending upon which mutation you have in a particular gene. That it's not just EGFR inhibitors. These inhibitors will be for these mutations, and those inhibitors will be for those mutations. And CLN-081 is a promising example of a new generation drug for exon 20.
Fantastic. A question coming in that is relevant here. EGFR, here we go, S768I is like a little orphan out there. It's an exon 20 checkpoint mutation. Do you know of anyone looking at it?
Yeah, so that was one of the ones that was present in John's paper. And believe it or not, I don't have every mutation memorized with what they're best targeted by. I don't know of specific drugs that are being developed for S768I, but the beauty of John's paper is that he finds that they group in functional classes so that you can develop a drug against a class of these drugs that targets many of these rare mutations specifically. So I think help is on the way. Our understanding is better for these agents, and given some time offline, I could research it and see what's known. But I don't think that anyone's developing a specific drug for that right now yet.
Fantastic. And I see the questions that are coming in, particularly around IO and HER2, and I promise we're going to get to them. So hang tight. Let's kind of finish off with some MET stuff, particularly the exon 14 skipping. And we've had 2 therapies approved for the treatment with this MET exon 14 skipping, Tabricta and Tepmetko. But as we've said previously, some tumors don't respond well and resistance does develop. So let's walk folks through the Chrysalis Ii trial, if you will.
Okay. The Chrysalis trial is using Amivantamab, the same antibody we talked about earlier, which has one side binds to EGFR and the other to MET, and it targets MET exon 14 skipping tumors. And so the Chrysalis study that was presented at ASCO looked at the anti-tumor activity of patients with exon 14. And again, like I've said for the other agents, they've saw a very high response rate. Overall response rates in patients who had no prior MET inhibitors, in fact, were about 47%. This is a small study, but most patients benefited, and there was an objective response rate that was very impressive with this drug in exon 14. Though I actually think that the drugs that we have, the targeted therapies that we have, are pretty good. The tepotinib and capmatinib are pretty good therapies for MET exon 14. And so we still have no head-to-head comparisons. We don't know which is best to start with. But again, there's a lot of activity in that space in drug development. And for example, it's the drugs that are on the market now also get into the brain quite well, which is, as I said initially, is a very important characteristic of new drugs.
That kind of is a perfect segue into discussing NTRK, where some follow-up data from a couple of different trials was showing similar response insofar as brain metastases. Can you talk a little bit about some of the information that came out about that specifically?
Well,
go ahead.
There's multiple drugs in that space as well. There's almost as many drugs as there are patients. The number of patients with NTRK is small, but as I said, if your tumor has it, it's very important to you. And so larotrectinib and entrectinib are both approved for this disease, but there's also, and these show durable responses and brain penetration. There's also resistance mutations that develop in NTRK treated with those. And there's exciting new drugs that have been developed in that space too. And one that we're studying is repotrectinib. That seems to be active against many of these resistance mechanisms as well. And osimertinib, which is active against T790M and really was an improvement over erlotinib. The hope is that if you can design these drugs that not only hit the primary target, but hit the common resistance mechanisms, that you'll have a more durable benefit from these drugs.
Sorry, I'm taking notes. Okay, before we jump into the next sort of category, if you will, I do want to respond and or ask you a question that did come from the live audience. The question says, I have the HER2 gene and I'm getting targeted therapy with positive results. Is there any update for this mutation since it's usually found with breast cancer patients?
Right. So breast cancer patients often have HER2 amplification, but the most common alteration of HER2 in lung cancer is this HER2 mutation. It's an exon 20 insertion mutation. And there was recently an approved new tyrosine kinase inhibitor in breast cancer for HER2 that's showing really good activity. And early studies in lung cancer show also good activity. But I've had some luck with using some of the other breast cancer drugs, trastuzumab deruxtecan, for example. I've seen very nice responses with that. So there are several options. Unfortunately, they tend to be a little more toxic than the other drugs that we've used, and not ideal. But there's active drug development going on for HER2 abnormalities in lung cancer as well. Perfect.
I'm going to jump into biomarker testing really quickly because I know we want to, I am watching the clock here. And I think one of the most important things that can come out of this from a patient perspective is for you to really give your opinion on how important biomarker testing is, and who and when should people diagnosed with lung cancer be receiving this type of diagnostic test.
Test early, test often. So I think virtually now with the approval of osimertinib in the adjuvant space, virtually every lung cancer patient, except maybe the earliest stage ones, should have biomarker and PD-L1 testing. And the PD-L1 testing obviously would be to help with guiding the combination of immunotherapy with their treatment. And that applies now even also to early stage patients. But we're going to talk a little bit about early stage patients later, but if we stick with metastatic patients, it really is true that everyone with metastatic lung cancer, especially with adenocarcinomas or any adenocarcinoma component, and many people argue that even squamous carcinomas should get biomarker testing, should get testing done, and not just get it done, but not start first-line therapy until they get the results back. And the NCCN now has 8 or 10 different actionable alterations, along with the immunotherapy marker PD-L1, that really should be tested and helps knowledgeable doctors match the patient's tumor and patient characteristics to the best possible therapy, rather than just picking one, randomly off the shelf. And then the other in many of the situations like we've talked about, tumors evolve to become resistant to our treatments in very specific ways, and more often we have drugs that target those resistance mechanisms, and the only way to identify those is by doing repeat testing at resistance in those cases. Now, there are cases where we don't have any biomarker-driven options after resistance, but I think it deserves to be looked for in most cases.
And I think it's important, especially just from your point of view, and because we talk about it a lot here in the living room forum, tissue biopsies versus liquid biopsies. Is there a time when a tissue biopsy wouldn't be sort of the gold standard and you have to use a liquid biopsy, or how does that all work? Because I know patients hear differing sort of opinions.
Well, liquid biopsies are getting better and better, and if you find a positive result on a liquid biopsy, I believe it, and I think I would be comfortable matching a therapy to that patient based on a liquid biopsy test. And it's very simple. Generally, the turnaround time is less than a week. It just involves a blood draw, and that's good for many different alterations. You can't test effectively PD-L1 with a liquid biopsy, but the targeted therapies, the mutations that are matched to targeted therapies, can often be effectively tested. But it's not as sensitive as a good tissue biopsy. And a good tissue biopsy will also let you look at it under a microscope and look at heterogeneity and whether it's may have a small cell component or other histologic features that may help guide therapies. And the blood-based tests generally have only about a 70, 80, 85% sensitivity. So sometimes a patient will have an actual actionable alteration, and the blood-based test will miss it. And it works better in patients with more advanced disease. So if you have minimal disease bulk, you have a 1 centimeter tumor and a positive single bone metastasis, your blood-based test may be negative and miss a driver alteration. So my practice is to really try to get a good tissue sample for tissue diagnosis and molecular analysis and PD-L1. But often on progression, if a tumor becomes resistant to alectinib, I will very frequently send a blood-based biopsy to look for ALK resistance mutations. And in that setting, it's pretty sensitive and very accurate and a very useful test.
Wonderful. And I just want to recap for folks. So what I'm hearing you say is if you find it in the blood, you're feeling confident that it's there. But if you don't find it in the blood, that's not necessarily telling you that it's not there, and you need to look at the tissue too. Perfect.
Okay, let's means so much to miss an alteration. You just don't want to miss one of these alterations.
Perfect. I want to jump into immunotherapy. One of the differences between immunotherapy and targeted therapies is that there's not necessarily a biomarker that's used that can directly predict whether or not that drug will work. We've talked about PD-1 a little bit. But because of that, there's ongoing research to really better understand which people diagnosed with lung cancer will respond well to immunotherapy. And there's studies highlighting new types of immunotherapy treatments, and such as vaccines and adoptive cell therapies and antibody treatments that were presented at ASCO. It's very complicated and probably a living room all on its own. And they're still being explored. The good news, really is that this is a heightened area of focus for a lot of folks, and a ton of research is being done in this area. But I want to start with something that you shared with me when we spoke last week that I was not aware of. And it's some big news data that didn't necessarily come out of ASCO, but is showing great promise. Can you talk a little bit about the A16 Acr study that's going on?
Well, it's not going on. It's been completed. Checkmate 816. It was also presented at ASCO, and it had an update on the outcomes in different subgroups. But I think it's a groundbreaking study, and just in general, we've made significant progress with immunotherapy in metastatic disease, and we now can tell our patients confidently, or I tell my patients, that there's a small chance that they might be cured of their metastatic disease with immunotherapy. It may only be 15% or 20%, but still, that's a real improvement over historically when nobody lived more than a few years. So it was natural that we would apply these therapies to surgically resectable lung cancer, also lung cancer in stage 3 treated with chemo and radiation. And the Pacific trial demonstrated that adding immunotherapy to chemo and radiation durably improved survival for stage 3 patients. But the new news in the last year has been the application of immunotherapy in surgically resectable patients, stages 2 and 3A, where 2 studies showed a benefit in event-free survival by adding immunotherapy after surgery, and atezolizumab is actually approved in that space. But to me, the most exciting development is this Checkmate A16 trial, which gave just 3 cycles of chemotherapy plus nivolumab before surgery, and a large fraction of patients were, at the time of surgery, had actually no tumor in their surgical specimen. And if you look at the rate of relapses of the patients on that study, there was a 25% improvement in event-free survival at 2 years and 3 years. And it even looked like there was going to be a major improvement in overall survival, but still kind of early to call. And if you think about it, surgery in lung cancer, even early stage lung cancer, is only about 50% 5-year survival. That many patients, even if the surgeon says he gets it all, many patients will relapse and die. So this, I think, represents a major advance in improving survival for surgically resectable patients. And I personally think that the treatment of immunotherapy before surgery is likely to be the best approach going forward, but times are early.
Yeah, so I just want to clarify for those who are watching live or who will come back and watch. Neoadjuvant means treatment prior to surgery, and then adjuvant, which Dr. Carbone touched on a little bit earlier in the targeted therapy realm, particularly around Tagrisso or osimertinib, is in the adjuvant and or post-surgical setting. So a ton of work is being done, to his point, that even though quite often the surgeons are like, nope, I got it, that way too often the cancer does come back or recur. So this, I think, is a perfect time to ask the next question that came from the audience, and whether or not there is any OS or overall survival data on neoadjuvant immunotherapy patient responders who decide to forego surgery versus patients that opt to go ahead and have surgery.
Well, that's a really interesting question, because there's 24% patients had no cancer in the surgical specimen, but this is no cancer by a light microscope. And, you can't look at every cell and determine, if it's a live cancer cell or not. Right now, I suspect some of these people may be cured, but I think that you're going to improve the cure rate by doing the surgery. And we right now really don't have a way to identify the people who don't need surgery. So I think it would not be a good idea to avoid surgery in those patients, even with a complete pathologic response. And it turns out that they have a very good event-free survival. But in the Checkmate A16 trial, they actually used immunotherapy only before surgery and not after surgery. And really, we don't know if doing it both before and after would be better. So hopefully we'll learn the answer to that. But I think surgery is the way the trials were done, and that's what should be done for the time being. Sometimes you can do less of a surgery if the tumor is big and it shrinks very effectively. You can take what would have been a pneumonectomy, taking out the whole lung, and only do a lobectomy, which is taking out part of the lung. This trial also showed that you were more often able to do minimally invasive surgeries with just inch-size incisions and Band-Aids when you leave the hospital in 3 days, compared to the foot-long incisions that they used to use for open operations. So you were able to do the minimally invasive surgeries more often with the neoadjuvant therapy.
I think this is a perfect opportunity for me to stand on my soapbox for a second. And although I know the folks watching, that either they themselves or their loved ones have already been diagnosed with lung cancer, but all the work that's being done in this earlier stage of disease just really goes to point back to the importance of early diagnosis and screening, where you are most likely to be cured, in spite of the numbers that are thrown out about upwards of 40% of recurrence rates for those with surgery. These new drugs used either before or after surgery are really helping to sort of boost those numbers. So I just want to give a shout out about screening for those of you who may know someone who is at risk, a family member, a loved one, your mailman, your neighbor. Talk to them about screening and whether or not they qualify. The guidelines were recently changed to include even more people, and roughly 16 million people in this country right now qualify, and only 4% of you or them are actually getting screened, where we can, I say we, where doctors like Dr. Carbone and his colleagues can be best set up to help you. So just a little plug for screening right there. And if anybody needs any information about it, I know our helpline's been popping up above, on the lower third of this programming all throughout, and anyone of the go-to team members on the patient support
Without
team can.
Screening, most patients are diagnosed with stage 4 disease. With screening, most patients are diagnosed with stage 1 disease, and the difference in cure rates is huge. So very good point.
Yeah. Thank you. Thank you. And now, sort of a last but not least is small cell lung cancer. And we saved this for last because next month's lung cancer living room is taking the whole hour to talk specifically about small cell, what's out there and what's coming. But it is such an important community, and we at GoTo really feel like a sort of left behind community. I know when I keep talking about when I first started in this space, but I know Dr. Carbone can and would agree with me. There wasn't even really a community for non-small cell lung cancer patients, let alone small cell, for a multitude of reasons. And we're really working hard on creating this sense of community and education and understanding around this piece. So stay tuned next month for a larger talk on that. But at this year's meeting in particular, there was some conversation or some data presented around a new immunotherapy drug. Can we talk a little bit about that?
Sure. I think you're referring to serplulimab.
Yes.
It's a new anti-PD-1 antibody. So it's like pembrolizumab or nivolumab. And right now, immunotherapy of small cell is definitely effective. And the standard of care now is the combination of immunotherapy. Right now, anti-PD-L1 drugs with chemotherapy for extensive stage. But this study that we're talking about now at ASCO is Astrum 005, and that combined this new drug, serplulimab, with chemotherapy in extensive stage small cell. It was a phase 3 study, and it involved many hundreds of patients, and it had an extremely impressive overall survival difference with a hazard ratio of 0.63, which means that you had a 63% chance, 63 or 37% reduction in the chance of death if you had this antibody added to your regimen of chemotherapy. And so I think that's quite exciting that it looks in the early data like it might even be better than the current standard of care. We also had a negative trial of immunotherapy in small cell, a combination of atezolizumab with an anti-TIGIT agent. They were very excited about a dual immunotherapy combination in small cell, and it turned out to be completely ineffective, unfortunately. So there's some good news and there's some bad news at ASCO for small cell.
What about there's two other phase 2 trials looking at Parp inhibitors and this sort of class of drugs. What's going on there?
Well, I think Lauren Byers at MD Anderson was one of the pioneers in this area. And small cell lung cancers often have damage to their DNA repair mechanisms, which results in a lot of gene mutations, a very high mutation frequency that small cells have. And PARP is a drug that makes cancer cells that are damaged in their DNA repair, having a hard time surviving. So it makes sense to use this drug in small cell, and there's some promising early data with combining PARP inhibitors with both chemotherapy and immunotherapy in small cell, but they're still early. They're not definitive phase 3 trials yet, but I think it's an exciting area of research.
Yeah, I would agree, and I think that the overall takeaway is that there is a lot of research happening across the board, as we've stated, but not unlike where we were talking earlier, 15, 20 years ago, and even farther back than that, there wasn't a lot going on in lung cancer at all, regardless of what type. And we talked a lot about what's happening in non-small cell, and we're seeing very similar sort of traction in the small cell space. So it's very encouraging and exciting. And like I said, at GoTo, I'm going to give us another plug before we close out. We really are pulling together this community and these small cell lung cancer specific education materials, as well as specific groups, conversations, blogs, and the like. So folks that are diagnosed with small cell lung cancer don't have to weed through all the non-small cell lung cancer stuff to find it, given that the same words are in both different diagnoses. So I want to end, we've got like 1 minute left, by asking you one last question, Dr. Carbone, and that is, how important is it, in your opinion, that people consider clinical trials as a treatment option, and where in their, from diagnosis on, should they start thinking about it?
Well, I'm firmly convinced that the best therapy is on a is available on clinical trials. The clinical trials are offering patients tomorrow's therapy today. Things that will be standard of care in 5 years are the things that are undergoing testing in clinical trials right now. And with the way we design our trials now, very science-based, very rational trials, the success rate of our trials is much higher than it used to be. I mean, oncologists used to go around scraping fungus off rocks and grinding up tree bark to try to find new cancer agents. Now, laboratory guys identify the precise shape of a pocket in a target molecule, and they design a drug for that pocket. These trials we're finding, even phase 1 trials, are having very high success rates. So I would encourage people at every decision point in their cancer therapies to at least consider availability of clinical trials. From new diagnosis to third time progression, consider clinical trials. I think they're your best option.
Fantastic. And I want to give a big shout out and a thank you to all of those people out there who have participated in clinical trials. The discoveries that have been made could not and would not have been made without you. And thank you to all of those who will consider a clinical trial down the road. I mean, you are the reason all of these amazing things are happening, are getting approved, and are getting to the person behind you who will be diagnosed. So thank you, thank you, thank you. I want to do a little bit of housekeeping before my thank yous. I already mentioned that next month's living room will be on small cell lung cancer. It is August 16th, and we have Dr. Jared Weiss from the University of Northern Carolina Cancer Center coming out, and the topic is living with small cell lung cancer, treatments and advancements bring new hope. So please, please, please join us for that living room. A huge thank you to Dr. Carbone for coming out and talking about what feels like a lot of head-spinning information, and really bringing it down to the type of conversation that I think most folks will be able to understand. We can't thank you enough for your continued support to not only GoTo Foundation, but to the lung cancer community. Thank you to all of you who joined and watched live tonight. Those who will come back and watch post-live, we're glad you're here. To the GoTo team that's on the back end, and those that are working tirelessly day after day to try to bring to you what the needs of our community are. And then Peninsula, Penn Media, sorry, I almost called them their old name. Thank you so much for all the back end work that you're doing on this to ensure that we're bringing this live broadcasting out to our community. I'd be remiss in not thanking our supporters. It's a long list, which I think points back to how important they think this programming is. So Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Merck, Mirati, Novartis, Regeneron, Sanofi, and Takeda. Thank you, thank you, thank you for all of your support as well. Until next month, everybody be well, and we will see you soon.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.